Everybody. My name's Gillian Robinson. I'm Director of ARK. I'm based at the University of Ulster. I'm very pleased to welcome you all to this ARK Seminar today, which is being held in association with Man Matters. We have a number of other people registered to attend, so there may be some people drifting in, but we decided to make a start, if that's okay with you all. So can I just say a little bit about ARK first? ARK is a joint centre between the University of Ulster and Queen's University Belfast. And ARK is involved in a wide range of activity, all designed to promote and support access to better social and political information in Northern Ireland. We run our own series of surveys, the Life and Times survey series. We have a lot of information relating to the conflict in Northern Ireland, particularly the Cain website, and we have a policy unit. Part of our dissemination activity is concerned with trying to bring relevant research to a wide audience of people. And so we were delighted to partner with Man Matters on this seminar today, where we will be looking at men's health issues and the impact of the recession on men's health. Before we go on to introduce our speaker, I'd like to invite Dermot Moore, who's the Assistant Director of WEA, who's responsible for the Man Matters programme, just to say a few words about Man Matters. Thank you.
Thank you. It really is just a couple of words. I am Dermot Moore from the Man Matters Project, and I'm also Assistant Director in the Workers' Education Association. The WEA is the lead in a partnership of 4 organisations who are delivering a 5-year lottery-funded project, and we're now in the 3rd year of that project. The other partners are the Men's Health Forum in Ireland, Home Start, and Parenting NI, who are the Parents Advice Centre. The main work of the project is to run courses for men around the themes of health, which is why we're particularly interested in the topic today, family, parenting, fathering, community volunteering, and learning itself, i.e. gateway classes back into learning. If you're interested in working with the project, as I say, mainly what we do is work with people to get learning and courses around those themes up and running for men. Please feel free to come and talk to us. Our leaflet's on your chair, so you have the contact details. And the main person in the room isn't me, it's actually Dawn, so give us a wave there, Dawn, who's one of the development officers for the project. So please feel free to talk to us about that. Thank you very much.
Thank you very much indeed, Dermot. I'd now like to introduce our speaker today, who's going to be speaking on this very important topic of men's health and the impact of the recession. As you know, very often men's issues can be somewhat marginalised and not that much to the fore, but I know there have been a range of activities, most recently through Man Matters and the other organisations that Dermot mentioned, who've been working very much to ensure that men's health issues and other issues relating to men are brought very prominently to the front of the social policy agenda. So Owen Metcalfe, who's the Director of the Institute for Public Health in Ireland, is going to give this seminar today. The Institute for Public Health in Ireland is an all-Ireland body, and Owen's going to tell us just a little bit about it in his introductory comments. But we're very much looking forward to hearing the results of the recent research that's been done and to hearing more about the work of the Institute. Thank you very much, Owen.
Good afternoon, everybody, and very nice to be here, and thank you for the invitation to both Gillian and to Paula to present on some of the work that in the Institute we commissioned in 2010. I suppose at the outset, it's not only thanks to the people for inviting me here, but it's thanks to the men and the organisations who helped us in putting this piece of work together. And I don't know, maybe some of you are in the room, or maybe some of the organisations are represented in the room, but without their participation and willingness to come forward, we wouldn't have been able to produce this piece of work. And I have some copies here of the report, but it's obviously available online as well. We can talk a bit about that later. But at the beginning, what I really wanted to tell you a bit about it was the Institute of Public Health, which was set up 13 years ago to bring about cooperation for public health on the island of Ireland, because I want to try and explain why this work was undertaken by us and the context within which we are doing this type of work. We are supported by both departments of health, by the Department of Health in the Republic of Ireland and DHSSPS in Northern Ireland. And we've been tasked with doing work in these areas: strengthening public health capacity, providing information, health intelligence for better health, and advising on policy. And some of the practical things that we've done in these areas, there's a very, very useful part of our website called the Health Well, which gives you an enormous amount of data and information in relation to various types of illnesses, diseases, and in relation to community profiles. So if any of you are interested in data, health information, health intelligence, please do check out this website and play around with it, because it can give you all types of information in relation to local areas, in relation to counties, in relation to resources, in relation to literature, all types of things, and that's available as part of the work that we do. Something else that we've been doing over a long number of years is the capacity building for public health. And one of the things that when we were setting out in this, when we were asked about, you know, if I asked you who are the great political leaders, or who are the great social scientists, or who are the great drama or literature experts, you'll be able to maybe think of people who will spring to mind as being leaders in our society. But if you're asked who are the public health leaders, are there people who immediately spring to mind? Can you identify, do those public health leaders have a profile that enables them to get messages across, to be influencers, to be advocates for particular areas, whether it's to do with maybe advocating for a sugar tax, or advocating for something that's very topical at the moment, to minimum unit pricing on alcohol. So are those people ready to step up to the plate? Are those people out there and ready to respond to the challenges that public health faces? And in general, we found that people weren't really able to identify and name people in that domain. So we spent a number of years developing a leadership program and putting people through a leadership program for public health as part of the capacity building. The other piece that we've been doing is concentrating on how to get our work influential in the policy-making arena, getting evidence in front of people who are taking decisions, developing reviews so that if you want to know what are the health impacts of transport, that you can have that evidence available to you in very accessible and immediate format.
Sorry to interrupt, Owen. We've had an emergency announcement. Some people have parked their cars in front of the Play Resource facility, just past here up on the right. If that's you, you need to move your car or you're going to be clamped. I'm very sorry, but I didn't want you to go out and find yourself in that situation. Sorry to interrupt, Owen. I guess so, but if you're in doubt, I'd check. Sorry about that.
It's certainly not worth 80 quid or whatever it is. Okay, like, so if I were you, I'd definitely move it and not take the chance. Okay, so we're about health intelligence, about capacity building, and about translating the evidence into practice. If people want to know what are the main impacts of the built environment on health, or transport, or education, or employment, then they can get the answers to some of the questions in a fairly short review of the evidence that's available internationally or nationally. And that, again, is part of the work that we do. But in thinking about health, we're informed by this particular construct, which is well known to people who are in the public health or in the health or social sciences field. It's a representation of how health is determined. And you have the age, sex, and constitutional factors, individual lifestyle factors, social and community networks, living and working conditions. And the two that just have been in the context of today's seminar, I would draw your attention to are kind of the work environment and unemployment. But the other thing that I think is worthwhile bearing in mind here is that if you look at the totality of that pictorial representation, you see that the healthcare services only represent a small portion of what it is that determines your health. I mean, if I was asking you here today, what is the single biggest factor that contributes to you being healthy and well, what are some of the things that you might come up with? Is it to do with the diet? Is it to do with exercise? Is it to do with the fact that you have a brilliant GP? Is it the fact that you have a brilliant hospital? You know, where do you rate those type of things in terms of prioritization? What is it that's needed to keep you well? On Valentine's Day, maybe it's a loving partner who actually did something very nice for you this morning. I don't know. That sort of little brush or stroke can be very influential. Context, relationships, networks, connectedness, all really vital dimensions in well-being. But frequently when we're talking about health, people think about what are the services that are there. And if you get ill, obviously you want a world-class health service, so you want access to those type of things, but they're not the type of services that keep you well in the first place. So this particular diagram has been adapted by many people in many variations on a theme, but it's attributed initially to Dahlgren and Whitehead. And it's a useful way of saying, when you're thinking about health, don't just think about health services. Think about what are the things that keep you well, ensure that you're well in the first place. Now, as I say, our work is really about generating public health knowledge, creating awareness, influencing policy, fostering networks and partnerships, capacity building, and strengthening cooperation. The other bit of this that's important to refer to is the all-island piece. Set up because geographical diseases don't recognize, infectious diseases, contagious diseases don't recognize geographical boundaries, set up because there are very similar smoking prevalence rates, very similar issues to be tackled. So wouldn't it be good if we were tackling these together across the island? Wouldn't it make an awful lot of sense? And again, just to go back to the issue that is, I suppose in a public health sense, being considered to be treated very successfully in the Republic was the ban on smoking in the workplace, something that, you know, then can be followed suit in other jurisdictions, and it can be used to leverage support across the island. At the moment, the issue of a minimum unit price for alcohol has been very much represented as something that both ministers, Poots and in the south, Dr. Riley, can be seen to cooperate on to reduce some of the harm that's caused by alcohol consumption. So, good reasons to be cooperating across the island, good reasons to be thinking about things together, to be seeing if something works in a policy sense in one context, can it be replicated in another? But the other issue that really is important from the Institute's perspective when it was established was that we would provide a focus on health inequalities that would help to differentiate us from what went on in public health departments or in the health promotion agency as it was back here at that time. And why health inequalities? Poor people die younger, suffer poorer health than their better off colleagues. And that's true for every step up the social ladder that you go. The better off you are, the better you have a chance of living longer, and the better off you have a chance of not being exposed to some of the illnesses that you are exposed to further down that social ladder. Now, what people sometimes use as the crudest measure of how healthy a society is in terms of life expectancy. So if you take a man at one end of the social class scale as opposed to the lower social class scale, you can have a difference in life expectancy of maybe 7 years. For women, that may be 4 years. If you put the two together, you might get a difference in life expectancy of 10 to 11 years. So your life expectancy and your chances of health can vary dramatically just because of where you're born and which class you're born into, and whether you're born male or female. Now that socioeconomic gradient has been increasingly recognized over the last number of years, and Professor Sir Michael Marmot is somebody who's done a huge amount of work on this area and has been very influential in the UK and in a world stage in drawing attention to this particular issue. 14 years ago, he launched the Institute of Public Health in Dublin. At that stage, health inequalities were not something that was really recognized as being a social issue that really needed to be addressed, a social issue that was unjust and unfair, that because of that accident of birth, your life chances, your life experiences varied dramatically. There's been a huge review done in England on health inequalities. Sir Michael Marmot has gone from being a somewhat shy, retiring academic to being an absolute luminary and charismatic figure on world platforms, bringing this issue to the fore, saying why is it that these inequalities exist and what can be done about them. Our institute has focused on this over the number of years that we've been in existence, and now I think you will find that if you go to policy documents in the social or health area, you will find reference to that discrepancy in health status and life expectancy. But what's often missing in that analysis is the difference between men and women as well. And there are differences in relation to geography, there's differences in relation to gender, and there's difference in relation to socioeconomic class. And sometimes the male and female bits can get left out of that. So I think today I just want to put us into that domain where we're thinking about that life expectancy difference, the differences in experiences and health status between men and women. And is that something that we should be doing something about as well? And in the Institute, we have been trying to focus as a small part of our work on men's health through working with the Men's Health Forum in Ireland. We did develop two directories which were looking at organisations that focused on men's health and had a role to play in men's health. A particular project that we're involved with in the moment is the Young Men and Suicide Prevention Project. They're just some examples of those of the focus that we bring to the men's health issue. But why did we undertake this particular piece of work? I mean, going back to the idea that, there's a concern about that difference. There's a concern about the health experience. There's a concern about how men's health is talked about or not talked about, how men's health is treated or not treated, how men think about their health. And one of the things that was happening very prominently and very significantly, particularly in the Republic a few years ago, was the recession was gathering momentum. Who is mainly impacted on in terms of a working life? It is the men in the society who carry the burden in many respects, both historically and traditionally, and feel the brunt of an awful lot of expectation with regard to the world of work, and we'll come on to that in a minute. But we wanted to see, was there a link between unemployment and health? Could we validate the links? What could be said about the links between mental health and unemployment, given that impending and ever-threatening and ever-increasing burden in relation to the economic climate? And could we get some stories from men which would help to illuminate the experience that they were actually having? Give people useful information I just want to go back here. What we hope in relation to these reviews is that policymakers, people who are interested, stakeholders, can get their hands on these, and they can actually use them as part of their work in terms of the pieces that they might be writing, the policies that they might be making, the decisions that they might be taking. So in the same way that we're hoping that this particular piece of work can be used in that context. So what did the piece of work involved with? What were the elements to the research and the consultation process? A literature and policy review looking at the international evidence, the challenges north and south, the response, surveys of locally based organisations, and meetings with groups of men, and then working groups to look at recommendations. Establishing the links, the implications for men's health demonstrated in varied circumstances internationally. Strongest evidence was in relation to mental health and stress-related conditions. Additional challenges highlighted in the reluctance of men to access services, and that might be something that you might have a view on as well when it comes to putting forward a situation about which you might do something about, and a deteriorating situation economically, both north and south. I mean, just the figures are that there's about, like, going from what was basically full employment in the Republic of Ireland a few years ago, which would be classically considered to be around 3% of their unemployment, it's gone to nearly 15% in the Republic of Ireland, 14.7%. And in the north of Ireland, the unemployment figure is around about 7% at the moment, but it has been increasing as well. And in the work that we did, just trying to find out, you know, is there a body of literature out there which validates a link between recession and unemployment and men's health and men's mental health? These reviews, the international evidence came up with the people who become unemployed were more likely to experience mental ill health, twice as likely to have short-term depression as those who were employed. The propensity for unemployment to trigger other problems with negative health impacts, like unemployment increases the risk of marital dissolution by 70%, and losing one's job can trigger problem drinking for 1 in 5 men. That's a piece of work that was done by the Social Exclusion Task Force in the UK in 2009. And changes in mortality and employment in 26 countries in a piece of work that was undertaken and reported in The Lancet in 2009 revealed correlation between increases in unemployment and increases in suicide. Direct link between resources spent on active labour market policies and a reduction in the effect of unemployment and suicides. A direct link between the resources spent on the active labour market policies and a reduction in the effect of unemployment and suicide. So if you can invest in it, you get a return on your investment. That's just a sample of some of the international literature. But then, just turning to the island, what did the researchers uncover in this context? Unemployment status is the most important predictor of psychological distress. This is work done by the Health Research Board in the Republic of Ireland in 2008. 30.4% of the unemployed reporting mental health problems, and more than 4 times more likely to exhibit psychological distress than those who were employed. Piece of work done by the National Suicide Research Foundation note that unemployment was associated with a 2- to 3-fold increased risk of suicide among men in the period 1996 to 2006. And the NSRF reported a 5% increase in the rate of hospital-treated self-harm in the period 2008 to 2009. And in the socially and economically disadvantaged wards of North and West Belfast, the suicide rates were more than 2/3 higher than the Northern Ireland average in 2010. And in 2010, it was the highest on record for suicides in Northern Ireland, 313, of which 240 were males. at the moment, there's 286,700 men on the live register in the Republic of Ireland. And whilst that figure was increasing between the periods of 2008 to 2009, there was also a sharp increase in suicide rates for those over 25. So when we looked at the international literature and looked at the literature that's available in the Republic and in Northern Ireland, we found that there are definite links between mental health and increased unemployment. What were the organisations who were dealing with men reporting as being of importance where unemployment or recession impacted upon their health? You'll see here that the 72 organisations who responded rated that stress and anxiety was very important. Drug and alcohol, if you look at the blue, which is very important, or the red, which is important, you'll find that nearly all of them rated these issues as being very important or important, but the stress and anxiety coming across as being really significantly important for everybody in this particular response of the organisations involved. Looking at stress, anxiety, drug and alcohol, physical health, family conflict, isolation, service access. I suppose one of the things that did strike me about that was the discrepancy between physical health and some of the other issues, where they reckoned it wasn't impacting upon their physical health as much as it was upon other areas. There's a lot of copy on this, but some of the issues emerging from the survey were an almost universal experience of the responding frontline projects saw health issues as being directly related to recession. True for organisations in both jurisdictions. It was true for more general projects such as family resource centres, citizens advice centres and community development projects. Mental health issues were rated more significantly than physical health. Incidents of stress and anxiety and difficulties in communicating were the most commonly identified related issues. Almost all report an increase in demand for help and support, which again has implications. Asking the organisations, what are they seeing about it? Asking the men themselves. And this was the stories from focus groups, and the men who were in these focus groups agreed to these quotes being used anonymously. These are just some, and they're just revealing as to what people are feeling in the context of their set of circumstances. Really strong affinity with the world of work. And the strain of doing nothing has been really demoralizing. This, I think, is really pertinent. Where's the safety valve? Where's the escape route? You know, and that's quite tricky now. You know, you're knocked down and you try to get back up again, and you're knocked down and you try to get back up again. Like, it's really hard. Where's the resilience, you know, get back up? And what you might do to alleviate the pain. And obviously the economic impact has been significant. The response, and I'll say a little bit more about that in a minute. And what does help? And in that context, the really enormously valuable work that a lot of people are going on with and engaged with. But just to, there's even more current work than when we did this, and a piece of work has just been done by a Health Action Partnership International and just reported on working for equity in health, and concerned that the current fiscal crisis will reinforce long-term trends of inequality, low pay and related poverty. In all countries, the unemployment rate for men has increased by 30 to 50% more than women in the current economic crisis. But it is not just about unemployment. There's a lot of people in work poverty. They're still working, but they're in poverty because the rates at which they're being paid are obviously too low. So it's not just all about getting a job at any cost, and I think that's an important point to be borne in mind. Any job is better than no job does not always ring true. Rather than considering labour market activation measures as a means of moving people from welfare to work with mixed results, these measures could be reorientated to include personal development. There's a lot about retraining, but the retraining and the work orientation courses, they must be relevant and appropriate. And there's a new initiative announced in the Republic of Ireland just yesterday by the Taoiseach and a whole raft of ministers aiming to create 100,000 new jobs in the next few years. Greeted with some scepticism, but again, there are indications that this issue is now being taken seriously, but what type of jobs are being provided? And we need to be really sure that the responses are linked to the research, and policies cannot be based on weak evidence potentially emanating from different contexts and different situations. So what are you going to do to address this? And one way of actually systematically and rigorously looking at the impact of any policy is by conducting health impact assessments on the policies. Again, a piece of work that the Institute has been very involved with, but not systematically undertaken in either the north of Ireland or the south of Ireland. Okay, so what's needed? Cutbacks cost money, so we have to make the case. Make the case for the priorities, the initiatives that communicate effectively, not just about ill health, but also about positive health and self-esteem in relation to male unemployment. The related improvements that need to take place across the service provisions. And in that context, I just want to in the conclusions that the type of response, and this is one of the things that I found pretty disturbing about the way in which men were reporting what it was their experience, was the lack of dignity that they were being afforded in many situations where they were coming into contact with service providers. And men in Derry have made some really important comments on what type of environment should pertain to allow people to feel that they are treated with dignity and in a humane and responsive manner, given the kind of situation that we're in, and ensuring that the physical environment is welcoming, comfortable and male-friendly. The worker having an adequate grounding and awareness of how men think, act, and the issues that they face. The requirement for self-awareness of how work with men makes the worker feel. Gendered perceptions as a worker working with men or attitudes towards men in general. No conflict between the needs of the men and the worker's own agenda. The ability to offer confidentiality, empathy, trust, and a non-judgmental approach. Now, unfortunately, I mean, that stacks up as a really good wish list. And in some organisations that may be true. And it was reported by some of the men in this survey that they were getting that type of response. But unfortunately, it wasn't the kind of the universal situation. but turning back, a formal and structured approach to supporting and developing community-based networks and mechanisms, creating absolutely vital spaces for men facing health challenges as a result of unemployment. And again, there's some really, really good work going on. And this seems to be so critical that people have the opportunity to meet, to talk, that they're provided with that type of exchange opportunity. The isolation is reduced and diminished. And one of the distressing pieces about this is that the people that are talked about in this particular piece of research work are those who were in contact with such organisations. So there is potentially a whole load of other men out there who aren't in contact with any services, who are even more isolated and more alone, and feeling that burden that has been placed upon them in the current economic climate, even more acutely than those that were responding in the context of this particular work. There are real, I think, opportunities to work together in terms of mutual recognition, and that's hearing from the people who are the service user and the service provider. So trying to have that integrated response is really critical. Just going back to the Northern Ireland piece, and this is the point that I kind of finish on, there is in the Republic of Ireland a men's health policy that has been launched by the government. It's a government document signed off with a number of action points, and one of the critical things about that men's health policy is that it is not just about the Department of Health. It has got action points for many other government departments. Now, getting them to commit and getting them to engage and getting them to fulfill their obligations may be slightly more problematic in fact than it is when it's on the printed page. But it is something that could be followed in the north of Ireland. I think discussions have begun about how a men's health policy might be a valuable document. Not that it in itself is going to change the world, but once the policy is there, it can legitimize so many people's work that is taking place in this area. It can give you a sense of purpose, a sense of legitimacy, a sense of status, a sense of authority. So it can be a valid document. Again, I think that is something that we should learn when we're working on a north-south basis. This piece of work was undertaken, the context of this piece of work was undertaken in 2010 by a research organisation called Nexus, and it was done by Brian Dillon and Paul Butler, and maybe some of you have met them. They undertook the work, and we edited and took the responsibility of bringing the research to the final stage of production and creating this report. I'm very pleased that I've been asked here today, and I'm very pleased that some more of you will have heard about the piece of work and some more of you will have heard about the Institute, and thank you for your attention.
Thank you very much indeed, Owen. I should have said just before Owen spoke that after his presentation he's happy to have some discussion, questions and answers, or any comments or observations you have. Many of you are working directly in this area and you may want to tell us a little bit about what you're doing, as well as maybe asking questions about the research. So I know Owen's happy to engage in a conversation with you if you want to do that. We're recording the seminar because we make it available on the ARK website afterwards for interested parties. So anybody who wants to make a comment or ask a question, if you could just wait till Brendan passes you the mic, and then means we can hear what you're saying. Okay, thanks. So if anybody wants to open the comments. Okay. Do you want to get back up to here?
Yeah. I mean, it really is, I'd love to hear, I know a lot of you are very involved with the topic. So what is your position, your perspective on what might be done? Any thoughts or comments? Yes.
Well, first of all, thank you very much. It seems a really interesting report and I look forward to reading it. I did want to ask a question, since it's done on an all-island basis, whether there was in fact much differentiation north and south.
Yeah.
I mean, you drew attention to some pockets in Northern Ireland, but if it's the case that unemployment is a determinant of so much in terms of health inequality, and if we've got an unemployment rate in the Republic almost double that in the north, I mean, do the indicators show that in terms of, whatever indicator you choose suicide, self-harm or whatever, or are they pretty much the same, north and south?
They're actually pretty much the same. One of the things that did come across was the similarity between the kind of figures that were reported in percentage terms, both north and south. Now, this research was undertaken in 2010, and the unemployment figure in the south has gone since even in those 2 years, it's gone up. Like, as I said, in the 4-year period, it went from 3% to 15%. So at this time, it might have been somewhere around about 9 or 10% or 11%. So it's gone up even more drastically in the last 2 years. But one of the things that I suppose, just when you're talking about north-south working, and that is what is very useful, if you can identify where the differences are. But in the context of this particular piece of work, the same type of things that men were saying north and south seems to be quite similar in terms of what they're reporting as how they want to be treated when they're in these circumstances, the type of things that make a difference to how they feel about themselves, their self-esteem, etc., etc. So that situation seems to be somewhat universal. But I think, and I think it's also a very limited piece of research, to be quite honest. Like, this is not like done. It was done with a limited number of organisations, with a limited number of focus group men, like 50 men. So it is hard to, on the basis of that size of sample, to be really definitive about the existence of difference. But it is, again, I suppose. Again, and this is like, we're a small organisation with a small amount of budget, and we try to shine a light on things, open them up for discussion and debate, and pick a topic. And to be honest about it, like, this whole area of men's health is one that isn't being kind of universally accepted as being really significant and important, and really deserves that kind of level of priority. So getting the kind of attention and focus on it is quite a struggle, and getting kind of departments to sign off on the fact that you're going to do a piece of research, shine a light on this area. But I think, yes, absolutely, like a valid point, yeah.
Thanks, Owen. Ian Banks from the European Men's Health Forum. And again, thank you very much, and congratulations on the report. You would be interested, you talked about commonalities between the north and the south of the island. Actually, if you look right across Europe, you'll see those same commonalities. And the report, which has just come out, of which Noel Richards, incidentally, and Colin Fowler and the Men's Health Forum Ireland actually contributed to, on the health of men right across Europe, supports exactly what you have found in this report. Now, and I've got some copies of that, by the way, if you want to.
Great.
This is the response to that report. But what I think is most important is not just identifying these problems, but as you've correctly said, how can we address them? Now, it would be very valuable to have this report fed into the response to the European Commission report on men's health, because it doesn't contain any recommendations. It simply identifies the problem, which in itself is huge, hugely valuable. But as you correctly said, we need to now be looking at the recommendations. You talked about Michael Marmot. I have nothing but admiration for this man. But even Michael Marmot didn't identify this difference between the male and the female perspective with this, and didn't recognize the incredible impact of social determinants and the difference between men and women when it came to suicide, for instance.
Yes.
And it was only the Men's Health Forum, actually, who actually addressed this to him, and then he rehashed the whole thing to include it. So even at that level, there's an ignorance, or a lack of awareness. Sorry, that's a better term. A lack of awareness of all this. But I do think we could combine this report with the European Men's Health report to give concrete recommendations and suggestions about what can be done. And I would suspect most of them will be political. Yeah. It won't be about doctors and nurses, and it will be political about the things that need to be done. And I think we need to understand that and address that.
Yeah, thanks very much, Ian. Certainly, I mean, when I was referring to the people who are public health leaders earlier, ever since my involvement, and I started with an engagement with men's groups back in the late 70s, I suppose, just groups of lads getting together and really feeling some kind of, I suppose, response to maybe the feminist movement or whatever, and that was very much on a personal level, and we'd come together. But as soon as I became more professionally involved, the one person who did come to the fore in terms of having a public profile and a willingness to stand up and articulate and advocate for this area was Ian Banks. So I mean, like, if we had more Ians or something like that, maybe we'd be making more progress. But it's obviously been a battle, and maybe a lonely one at times as well, and disappointing when you find somebody like Marmot would not have included that perspective in such a seminal report. Absolutely, I agree with that, Jim. Please, any more comments? Yes.
Hello, I'm Shay Franklin from Dublin, and I'm a man that spends a lot of time with men in community groups, and I'm struck by the fact that those men speak this way about their experience, and the tiny number of men that engage with men in community, with themselves in community groups. Therefore, those that are outside that remit, and those that really struggle, if you talk to anybody working with men on a community basis, the struggle of outreaching and reaching men at all. So there's all of those men out there who are even worse off. And I know you said it, and I just want to headline it. It is so remarkable, the struggle that men have to engage at all in any way, and to get past that piece of breaking down the barrier. And as they become unemployed, the struggle, the shame of not wanting to be seen on the street, of not all the things where they've lost some sense of their identity, whatever it is. And no matter how much we hate about the conditioning that makes men believe that they are their job, that is the case. And the older they are, the better conditioned they are. Yeah. As a 60-year-old, I know I've spent 60 years becoming this man, so that's the way we. So I just wanted to highlight that.
Yeah, and I suppose it's just going back to what can be done about that. I mean, like one of the things is like that, and it's again a kind of in what can be done to support men in coming to the services, even like so that they're not in contact, and that whole idea of the GP's waiting room not being male friendly, or as a boy what kind of stoic attitudes you're ingrained with, rather than when you have something wrong with you that it's okay to come forward. But then, and the whole emotional context, I mean, like presumably most of the people in the room could write discourses on all this kind of whatever we call it, gender stereotyping or whatever, but I think it is really how can we begin to address that, and what is the type of things that make an impact, both in terms of that orientation, and then when it comes to a crisis, what happens then? Because if you're traditionally kind of blocked off from any kind of response, and you feel it's inappropriate or demeaning to kind of engage in that type of what should we say, acknowledgement of the difficulties that you're in, then in terms of a crisis, it's even more problematic, that you're faced with this situation and more alienated and more alone and whatever. But again, on a positive note, there are some organizations, people like yourself, that are doing great work. And maybe this is, a matter of kind of advertising those services, getting people to spread the word that that type of thing is available, that it is safe, it is possible, it is permissible to do that type of work and to engage in that type of work.
Just one quick response. The other element is that on the services side, they are also gendered in terms of their response to men. So this kind of report landing in a community context can turn that window just a little piece.
Yeah. Thanks. We did send the report to all the Secretary Generals and Permsecs of the relevant departments, both north and south. Yeah, behind it.
Hi, my name is Linda Johnson, and I just wanted to comment on what you were talking about last. I'm actually doing a documentary looking at midlife transition, so I'm specifically looking at the midlife stage, and I'm really keen to talk to men. I've spoken to several men's groups, so even if there's anybody here in the room, I just feel that one of the things, what I really want to do with my documentary is to, yes, highlight the issues around midlife, men and women, but also to promote what's already happening here in Ireland. And I'm specifically looking at Ireland, nowhere beyond, I'm just looking at Ireland. And so I want to know what groups are out there, I want to know what they're doing, I want to hear men's stories of how they've been helped through the groups. So can I just encourage anyone just to come and see me afterwards, and if anybody, I'll come to where you are, I'll travel to wherever you are, and just, I think, telling a story, someone telling their story. And I think even the whole thing of men just expressing what's in there, and so that other men can identify with that. I mean, I've got 5 sons, and I've done a lot of research into boys and men, and I know that it is difficult for them to express things, and it's really to encourage that, and to encourage society to stop all this nonsense that's been going on, allow men to have a voice in whatever way that is. So I'm really keen to really use this as a platform to look at the positives that are happening, and let's look at it in a positive way and see what good things are happening. So please come and see me afterwards, anyone who wants.
I know Gillian's chairing this, and she's standing up, so that must mean something.
No, I'm just standing up so I can see if there's anybody else.
Okay, any quick comments? I'd love to hear some quick comments, like just very quick. Anybody, quick comments? Comment there? No? No, sorry. No. Any quick comments from people? Is it good, bad, better, worse? Anything? Yes, just very quick comments, thoughts.
More a question than a comment. I was given a paper last week in the South, Una Lynch. I was given a paper last week on the South, and I was looking at mortality rates and comparing, and I couldn't for the life of me find statistics even at county level that would give me information on life expectancy at county level in the 26 counties. Now here we can go into the NICVA website and we can get really good small scale data which makes visible the inequalities. Where would I go in the Republic?
Go to the Health Well and you'll find it for every county.
Every county in Ireland?
Yeah, now it's not disaggregated below county level, so that's one of the difficulties about the statistics in the Republic as opposed to statistics in the North, and that's one of the things that again we're faced with all the time and trying to say, look, NICVA is fantastic, they do it much better up there, why can't we have it at that level in the Republic? And one of the things that has come out in the latest census that was just done, there is a local area denominator now and a code, so we'll be able to get that kind of level of data at a much lower level than we have historically. But you're right, but go to the Health Well and you'll find every county. I'll go to the Health Well,
but I talked to one of the directors of public health, thinking, you know, how do you do your work, you know, without this information? And his response was, it was just really, really difficult. And I'm thinking, if someone at his level doesn't know that information, how will people at grassroots level, how will the men on the street who are trying to advocate for more resources know that? So certainly I'll be going to the Health Well this evening.
Please do. Have a look. And then if you don't find what you're looking for there, give me a call, okay?
Yeah, okay. Thank you. Any
more quick comments? The data, whatever we call them, deficits are the plague of the public health practitioner's life. Like, you know, but it is much more standardized, much more systematic in the North in general than it is in the Republic. Yes, that's what we would find. Yeah. Quick comments. Anybody else? Any other? Yeah.
Contact Lifeline. We would have people called into Lifeline for suicide and self-harm. And in particular, what we were looking at, you were saying about North and West Belfast, and we would have high use of the service by people in North and West Belfast compared to per capita. However, in the western areas, the west of the north of Ireland, and along the border counties, the poor uptake of the service.
Yeah.
And you know, we find it promoted quite well in the cities and in the the area in Belfast and whatnot, and even into the north, Northampton. But as you go along the border, for some reason, it's promoted, but the uptake is not there. So there's something about when you go to more rural areas, when you go across the border to the border areas, why men and women, but particularly men, not availing of this service. You know, they have equally high levels of suicide and self-harm, but they're not talking, they're not reaching out for the support that's there for them.
Yeah, I mean, one of the things we talk about is the north-south piece, but we also kind of forget about the east-west piece as well, like, and the division there. It's just beside you, Ian, first. Yeah.
Thank you. Firstly, I popped out for a minute, so hope somebody already didn't do this, but to give a plug, on 13th of March, there will be a seminar in Mansheds. So Mansheds is one of the community-based networks that you're referring to here that may have an impact upon these issues. So you would love to see people at that as well. I don't have the information with me, but if you pop up and talk to me, I'm sure, or Dawn, who identified earlier, or Colin Fowler, who's here as well. All of us know a little bit about that. And the second thing is just a question. One of your other reports was on education, the health impacts of education. Did you see any correspondence or find any links between the issues of education and men and unemployment in this research?
well, in the bit that we did on education, yes, very strong links. Education has been a kind of a real marker for economic prosperity, but also for employment. So I mean that, you know, the more education you have, the longer you live as well, like, you know, and the better health you have, and that's well recognised as well. Yes, Ian.
Yeah. Sorry to come back again, but there's one thing missing in all of this. Sorry.
Only one.
Only one. And I'm afraid after 20 years of working in men's health, you know, I'm full of it now. And that is anger. When I see those statistics for suicide of young men, yeah. I'm just angry. I'm not just upset, and I'm not just, you know, academically interested. I'm angry at this. I'm angry at society that just seems to shrug its shoulders and say, but that's what men do. I'm angry at the medical profession that they say there's nothing that can be done about it, which is crap. We know we can do things about it. And I'm angry that the finger is always pointed at men themselves, as if it's all the men's fault. That just by owning a Y chromosome somehow means you should die early somehow. And I'm angry at that, Owen, and I think that's what's missing out there at the moment, is that anger that it's acceptable that these things happen, that young men in low-income groups take their own lives, that somehow that's acceptable. Well, it ain't acceptable, and the politicians are going to have to start to understand that we are getting angry about the complacency that's out there. And I think this report will help with that.
I'm just stunned by, like, you know, well said, yeah. I just, like, you know, that road traffic accidents graph and the suicide graph, like, you know, if I was to go back 10 years, like, you had the number of road traffic accidents were killing in the Republic, very roughly 500 people a year. In suicides, 250 people. Now those have completely swapped. There's 250 road traffic accident deaths, and there are now 500 suicide deaths in the Republic. And you look at the massive amount of resources that have been plumped into road traffic accidents. There's a special commission, a special report, special task force, blah, 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 blah. And on the issue of suicide, there isn't, you know. So, I mean, I think it is, I think you're right, but I think it's very difficult to mobilize that anger and to mobilize that in terms of, like, making a statement, having the advocates, going back to the leadership again, impacting in the corridors where that kind of position or statement can actually make a difference of what it is that you'd want to do in terms of, like, right from the conception, really, in terms of what happens to young people, how stereotyping begins, and in the education system, and then, you know, a lot of the to do with the binge drinking as well. Like, to be quite honest, like, this, the connection between drink and suicide is really pronounced as well. That's very depressing. Well, the anger as well as the yes, sorry.
Yeah, my comment was just, I was going to make a slightly different comment, but in response to Ian's, I work in condition management program, which may not be very well known. It's more or less with people that are not working. They're off on employment support allowance or incapacity benefit. First point I was going to make was that the vast majority of people who come to our service, while we're set up for all sorts of physical and mental health problems, have mental health problems. About 85% have a primary mental health problem, and the ones who don't have a primary mental health problem have a secondary mental health problem. So that was a comment, just that the masses of people coming through are with mental health and stress. But the second point I just wanted to make in response to Ian was I went to a launch of a young men and suicide document that was launched a couple of months ago. And the really big thing that stood out for me as a healthcare professional was when a man comes to you, when anyone comes to you with suicidal ideas or feeling really depressed, the health service is inclined to say, gosh, you've come to the wrong service. What you need to do is you need to go to the crisis response drugs team, you need to go to the alcohol team. What we need to say is, thank goodness you've come to me, and I'm going to do my best to deal with you. Whether you're actually at the right pocket for you, I'm going to do my best. I've got the skills, I'm going to try and use them, and let's not worry so much about shipping people off to signposting them here, there and everywhere. Let's try and deal with them when they come forward.
Well, it goes back to some of the kind of criteria that were formulated by the people in Derry about what, you know, it is, what a resurfaced response should be like.
Yeah.
So the dignity, yeah.
Okay, well, I think we're going to have to draw things to a close. Thank you all very much. It's clear that Owen's given us a lot of food for thought. Many of you in the room are already very actively engaged, and it's very interesting to hear how people can see